Madam, we are live now.
Yeah. Hello.
Yes, madam, we are live now.
Yeah, you will be interesting.
Aditi, please share the previous slide. Aditi, shall I start? Your screen is visible.
Okay, so I'll start the session.
Madam, good evening all, and I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's session on mainly infertility, and it's my pleasure to introduce our guest, today's speaker, Dr. Neetu Singh, madam. Madam did her MBBS in obstetrics and gynecology, DND on obstetrics and gynecology. Madam is the owner and consultant at Pinnacle Hospital, Dahisar, Appet Hospital, Borivali, Runga Hospital, Mira Road. And in terms of area of interest, infertility, high-risk obstetrics, and endoscopy. In terms of professional achievements, Madam is a consultant and owner, Pinnacle Hospital, Dahisar. And Madam has a teaching experience of 3 years. And in terms of publication, Madam published many papers in national and international journal. And apart from that, she won for free communication scholarship best paper presentation award in Jabalpur Obstetrics and Gynecology Society in 2011 and 12. And social responsibility like taking lectures to increase public awareness is sublight PCOS, etc. So with the short introduction, I request Madam to take over the session, and meanwhile, I request all the participants for your active participation. And post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, for your valuable time on our platform Shield Connect, and over to you, Ma'am, for further proceedings. Thank you very much.
Yeah, thank you. Thank you for the warm welcome. Yeah, Suman, just start the slide.
Yes, Madam.
Yeah. Share the slides, please. So basically today we'll be talking, or rather having a brief discussion on male infertility. As we know, yeah, second slide. Start the slide, only the slide. Yes, infertility, as we know, is the inability of a sexually active, non-contraceptive couple to achieve spontaneous pregnancy in 1 year. This definition is as per the World Health Organization. Male infertility, you're going too fast. Yeah, go back to the previous slide. Yes, thank you. So primary infertility is defined as a couple who has never conceived, and secondary infertility refers to a couple who previously had pregnancies but is facing failure to conceive subsequently. Infertility is not just a woman's concern. About 1/3 of the infertility can be attributed to male alone factors and about 1/3 to female alone factors. Next slide. Male infertility refers to a male's inability to cause pregnancy in a fertile female. Next slide. Looking at the epidemiology, about 15% of the couples do not achieve pregnancy within 1 year and seek medical treatment for infertility. In 50% of involuntarily childless couples, a male infertility associated factor is found, usually together with abnormal semen parameters. Next. Next slide. In the Indian scenario, male factor infertility accounts for around 40 to 50% of infertility, and it affects almost 7% of all men. Normozoospermia was observed in about 35% of individuals in India, oligozoospermia in about 34%, actinoteratozoospermia in 19% of the general male childbearing age population, and azoospermia in about 10.7% of the men. Next. What are the problems that cause male factor infertility? About 35% of infertility is related to male factor problems. These can vary from being structural abnormalities, that is, sperm structure defects, sperm production disorders, ejaculatory disturbances in the male partner, or immunological disorders in the male partner. Next. So what we just discussed, the causes of male infertility, in about 34% of the individuals, the cause is unexplained. About 5% it is immune factors, around 10% it may be because of hypogonadism, it may be because of varicosities in about 17% of the individuals, systemic diseases in around 3% of the population, male population, 6% may be because of sexual factors, 9% because of urogenital infections, 8% because of undescended testes, and again other causes like go around for about 8% of the population. Next. So basically here is a graph which shows causes of male factor infertility. Starting from hypothalamo-hypophyseal dysfunction, it can be because of pituitary insufficiency, hormonal disorders like hyperprolactinemia, genetic defects like syndromes like Kallmann syndrome, hemochromatosis, pituitary tumors, or chronic illnesses. Coming to the testes, it may be at the testicular level due to infection, Klinefelter syndrome, testicular atrophy, Y-chromosomal deletion disorders, or it may be because of systemic disorders. In the seminal tract disorders, it is either because of retrograde ejaculation or because of an obstructive azoospermia. Autoimmunity may also lead to immunological disorders and psychosomatic disorders. Next. The risk factors for male infertility. Precocious puberty may occur at a young age. It's a risk factor for infertility. There may be delayed puberty occurring at an older age. It can be because of exposure to toxic substances like lead, cadmium, mercury, radioactivity exposure or exposure to X-rays, smoking cigarettes or nicotine or tobacco, and heavy alcohol consumption. Next. Now, obesity is a very important risk factor for male infertility. We can see like in Indian population, around 13% of the men fall in this category, wherein obesity is the risk factor for their infertility. Next. Other risk factors for male infertility include exposure of the genitals to high temperature, surgical injury to the vas, especially after inguinal hernia repair on both the sides, or if there's a history of having prior vasectomy or major abdominal or pelvic surgeries, if the male partner has a history of undescended testes, having experienced trauma to the testicles, being born with a fertility disorder like we just saw Kallmann syndrome, Klinefelter syndrome, medical conditions like diabetes, sickle cell disease, and patients who have undergone surgical treatment or radiation for treating certain carcinomas. Next. Thermal toxicity has cryptorchidism has provided a model by which the effects of heat can be studied on sperm production. So basically increasing the testes temperature to than that of the abdominal cavity significantly impairs spermatogenesis. We see this in men who especially have profession who are working in furnaces or industries wherein there is a higher temperature, or individuals who are cooks. Radiation. Testes directly exposed to ionizing radiation suffer germ cell loss and Leydig cell dysfunction. Another risk factors which has been proposed is the use of cell phone, which causes a linear decrease in the sperm count, motility, viability, and normal morphology. Next. Infection and inflammation are proved causes of male infertility. Infections of the testes, epididymis, prostate, and urethra individually may lead to male infertility through the anatomic and functional means. Common organisms which affect the prostate are E. coli, Pseudomonas aeruginosa, Klebsiella proteus, and Enterococcus species. Organisms affecting the epididymis include Neisseria gonorrhea, Chlamydia trachomatis, E. coli. Affecting the urethra include Neisseria gonorrhea, Chlamydia trachomatis, Mycoplasma species, Trichomonas vaginalis. And specific viruses which affect the testes include rubella virus, mumps, Coxsackie virus, Chlamydia trachomatis, Neisseria gonorrhea, E. coli, Pseudomonas aeruginosa, Streptococcus, Staphylococcus, and Klebsiella group. Mycobacterium tuberculosis may affect any reproductive organ and cause scarring of the vas deferens and epididymis, just like how it affects the female genital tract. Next. Complications of male infertility. Male infertility is a major social and emotional stress on the male partner, as well as it causes relationship difficulties amongst the spouse itself. The treatment options are expensive and may end up involving assisted reproductive techniques. There's an increased risk of testicular cancer, melanoma, colon cancer, and prostate cancer. Next. Clinical evaluation of the infertile man. Going to the history, specifically history for illnesses or injury affecting the testes have to be taken. History about the pubertal development, sexual performance, fertility exposures, the occupation and habits, especially about alcohol smoking, have to be taken care of. On physical examination, general examination, signs for virilization, gynecomastia, body proportions, body mass index has to be examined. Scrotal examinations, testicular size, epididymis, examination of the vas and varicoceles. Looking out for varicoceles has to be done. Next. Basic investigations of an infertile man include semen analysis as the first parameter after the general history taking, and the second are the blood tests, which include the hormonal measurements. In semen analysis, we assess the semen volume, the sperm concentration, motility, morphology, and the presence or absence of anti-sperm antibodies. In the hormonal measurements, we go for luteinizing LH hormone, FSH, prolactin, testosterone, and SHBG levels. Imaging includes if there is clinical suspicion of a varicocele or if we are suspecting obstructive pathology, then imaging techniques include scrotal ultrasound, transrectal ultrasound of the prostate and seminal vesicles, and MRI imaging of pituitary if required, if we are suspecting any pituitary adenomas or tumors. Testicular biopsy is done in the form of needle aspiration, wherein we do to reconfirm a zoospermia. Next. Coming to the semen parameters, we all know this. Spermia is failure of emission of semen. Oligospermia or oligozoospermia refers to an individual whose sperm count is less than 15 million per ml. Azoospermia is the complete absence of spermatozoa in the semen. Actinozoospermia is reduced sperm motility. Necrozoospermia is spermatozoa are dead or motionless. Teratozoospermia refers to a condition wherein more than 70% of the spermatozoa present with an abnormal morphology. And oligoactinoteratozoospermia refers to disturbances in all the three variables. Next. Semen examination can be in the form of macroscopic parameters as well as microscopic. In macroscopic, we look for the volume, the appearance, color, time for liquefaction, viscosity, and the pH. In microscopic parameters, we study the sperm concentration, sperm motility, sperm morphology, leukocyte concentration, and agglutination. Next. WHO normal cutoff values for semen characteristics. The ones which we follow now is the WHO 2010 guidelines. According to this, a minimum volume of 1.5 ml should be per ejaculate. Minimum sperm concentration should be at least 15 millions per ml. The sperm count should be minimum 39 millions per ml. Minimum motility is 40%, with progressive motility, that is A plus B grade, being 32%. Vitality of 58%, morphology at least 4% of the sperm formed spermatozoa should be normal morphologically, and the peroxidase positive leukocytes should be less than 1%. Next. Semen pH. The semen sample is primarily made up of alkaline fluid which comes from the seminal vesicles and acidic fluid which comes from the prostate. The pH of the two fluids combined should be in the range of 7.2 to 8.2. A pH of less than 7 in a semen sample may indicate an obstruction in the ejaculatory duct. This results in an absence of alkaline secretions from the seminal vesicle fluid. A higher pH could indicate the presence of an underlying infection. Next. Sperm functions. Basic function is to fertilize an ovum and contribute to the chromosome. Sperm functions, including the potential for movement, cervical mucus penetration tests can also be done. Sperm capacitation, zona recognition, acrosome reaction, and sperm oocyte fusion. These are the other sperm functions which are required for fertility. Next. Now, treatment. Coming to the treatment of male infertility, the indications include if there is extreme oligozoospermia or zoospermia, or there's a low volume ejaculate or impotency. These we try to treat. In general care, we have to ask the male partner to go for weight reduction if he's obese, avoidance of substance abuse like alcohol and smoking and nicotine in various forms. If the patient is proved to be hypogonadotrophic, having hypogonadism, HCG injections 5,000 units intramuscularly once or twice a week may help. HMG or pure FSH 75 to 150 international unit doses is added to the HCG. Dopamine agonist like cabergoline is given in patients who have proved hyperprolactinemias. Pulsatile GnRH therapy may be given in case of Kalman syndrome. Next. In the hypergonadotrophic hypogonadism group, insemination with a donor sperm or adoption is the option because it indirectly indicates testicular failure. IVF with ICSI, IVF with intracytoplasmic sperm injection may be done in cases of severe oligospermia. Clomiphene citrate 25 mg orally daily dose or 3 months increases the serum levels of FSH, LH, and testosterone. It can be tried. Presence of anti-sperm antibodies. If there's presence of ASAs, then the answer is intrauterine insemination should be opted for. If there is leukocytospermia, then a prolonged course of antibiotics, generally doxycycline or erythromycin, has to be given for a minimum period of 4 to 6 weeks. If there is retrograde ejaculation, phenylephrine, which is an alpha-adrenergic agonist, or even tricyclic antidepressants can be tried on the male partner. Genetic abnormality, if there are proved genetic abnormalities, options of artificial insemination or with donor sperm or IVF with donor sperm can be given as an option. Surgical treatment is valid only if there is obstruction of vas is suspected. It is corrected by vasoepididymostomy or vasovasostomy. If there's a hydrocele surgery may help. Orchidopexy is indicated in cases of undescended testes. Next. If there's impotency, psychosexual treatment may be helpful. For erectile dysfunction, sildenafil or tadalafil in the doses of 25 to 100 milligram, half to 1 hour prior to the sexual act can be advised. ART indications, ART for males, male factor infertility includes either in the form of IUI, that is intrauterine insemination, testicular sperm extraction, percutaneous epididymal sperm aspiration, microsurgical epididymal sperm aspiration, or intracytoplasmic sperm injection. Next. Coming to the role of oxidative stress in male infertility, we know that current evidence links oxidative stress to male infertility. It reduces sperm motility, sperm DNA damage, and increases the risk of recurrent abortions and genetic diseases. Oxidative stress is detrimental to fertility, pregnancy, and genetic status of the newborns. Next. It was found that oxidative stress affects negatively the testicular microenvironment and ends up causing a deficient spermatogenesis, damages to the sperm DNA, as well as reduces motility and altered morphology of the spermatozoa. Next. So, systematic treatment of an infertile man with antioxidants has received great interest in recent years, and it seems to have some clinical benefit. The antioxidants used in infertility treatment commonly include vitamin E, which improves the motility. Advised dosage is 300 to 600 milligram per day for 6 to 12 weeks. Vitamin C, that is ascorbic acid, it improves the sperm quality and function, dosage being 1000 milligram per day. Vitamin B12 is useful for synthesis of DNA and RNA. For oligospermic and asthenozoospermic individuals, the dose is around 1000 to 1500 micrograms per day for 6 months. Folic acid is an additive to other drugs to improve the cell function, dose being 5 milligrams per day. Drugs like pentoxifylline may improve microcirculation and improve the count and motility, dose being 1.2 milligram per day for 3 to 6 months. Pentoxifylline mostly in sickle cell individuals can be tried. Next. Antioxidants used in infertility treatment in males further include arginine. Minimum dose is around 4 milligrams per day. It improves the sperm motility. Selenium is an antioxidant as well as anti-inflammatory, found to be highly concentrated in the male reproductive tract. Highest concentration is found in prostate. The recommended dose is around 225 micrograms per day. Glutathione also has a positive effect on sperm motility, around dosage being around 600 milligram intramuscular daily, but it's not very popularly used. L-carnitine and L-acetyl-carnitine have an important role in sperm cell metabolism, highest concentration in the epididymal fluid. It is useful in oligosteroteratozoospermic individuals and individuals who have low-grade varicocele. Coenzyme Q10 is a component of mitochondrial respiratory chain and is available as 50 to 100 milligram soft gel capsules. Lycopene is the most potent lipophilic antioxidant and carotenoid antioxidants. It protects the sperm from damage by reactive oxygen species. Next. L-carnitine is involved in sperm metabolism, fueling important activities like sperm motility. The main function of L-carnitine in the epididymis is to provide an energetic substrate for the spermatozoa. It may be involved in the successful maturation of the sperm. L-carnitine is necessary for the transport of fatty acids into the mitochondria to produce energy. Low levels of L-carnitine reduces fatty acid concentrations within the mitochondria, thereby leading to decreased sperm motility. Next. Coenzyme Q10 is a vital antioxidant omnipresent in almost all body tissues. It is particularly present at high concentration in the sperm mitochondria, involved in cellular respiration, and plays an integral role in energy production. This contribution rationalizes its use as a pro-motility agent and antioxidant molecule. Furthermore, it inhibits the superoxide formation, delivering protection against oxidative stress-induced sperm dysfunction. A significant negative correlation between coenzyme Q10 levels and hydrogen peroxide has been reported, and a linear correlation between coenzyme Q10 levels in seminal plasma, sperm count, and motility was detected. Next. Selenium is an essential trace element whose involvement in spermatogenesis is thought to stem from its ability to protect the sperm DNA against oxidative stress damage. Selenium is a major constituent of a specific group of proteins called selenoenzymes. Its antioxidant properties are thought to stem from its ability to augment the function of glutathione. More than 25 selenoproteins exist, such as phospholipid hydroperoxide, glutathione peroxidase, and sperm capsular selenoprotein glutathione peroxidase. This helps maintain the sperm structural integrity. Selenium deficiency has been most commonly associated with morphological sperm mid-piece abnormalities and impairment of the sperm motility. Next. Zinc is an essential trace element having important role in DNA and RNA metabolism, signal transduction, gene expression, and apoptosis. It is an antioxidant that decreases the production of hydrogen peroxide and hydroxyl radicals. Zinc concentration in the seminal fluid of fertile men is significantly higher. Protective mechanisms against sperm abnormalities including hypertrophy, hyperplasia of the fibrous sheath, axonal disruption, absent or abnormal midpiece. Next. Importance of treating sperm DNA fragmentation. The genetic integrity of the sperm is crucial for successful fertilization and normal embryo development. Embryos derived from sperm with highly fragmented DNA have poor result. High sperm DNA fragmentation affects the blastocyst development. Higher the DNA fragmentation levels, higher are the chances of failed assisted conception treatment and miscarriages. Sperm DNA fragmentation is higher in subfertile men with abnormal sperm parameters. Men with normal sperm parameters are also found to have high sperm DNA fragmentation. Next. The management of sperm DNA fragmentation. Firstly, lifestyle modifications, which include cessation of smoking and alcohol intake, weight management for obese men. Antioxidants should be used at least for 2 to 3 months for its effect to be visible. These include vitamin C, the doses have already been discussed. The antioxidants include vitamin C, vitamin E, folic acid, zinc, and selenium. Treatment of underlying pathological conditions like if there is proof infection or varicocele, the avoidance of environmental exposure to toxins and judicial medical use of radiation, reducing the abstinence period or serial ejaculation every 24 hours reduces the SDF by up to 25%. In cases with uncorrected DNA fragmentation, consider surgical sperm retrieval. Next. This is a slide showing the evidence of sperm DNA fragmentation and its results on further fertility. As we see, just reading the outcome, embryos with a high sperm DNA damage are associated with early pregnancy losses, and modestly increased pregnancy chances occur after IVF in cases who have low level of DNA damaged sperms. In ICSI group of in ICSI sperms are injected into the optimal environment of the ooplasm within a few hours of ejaculation, thus reducing the chances of lab-induced damage to sperms. In IVF couples with low levels of sperm DNA fragmentation had LBR of 33%, and the ones with live birth rate of 33%, and the ones with high levels of sperm DNA fragmentation had LBR of 13%. Sperm DNA damage not found to be predictive for ICSI treatment, because in ICSI we immediately inject the sperm into the ovum. Sperms, excuse me, sperms form up to 40% of infertile men have high level of reactive oxygen species. High levels of sperm DNA damage are associated with increased risk of pregnancy loss, regardless of the in vitro technique applied. Moving to the next slide. Next slide. Now we have coming to the certain important ingredients useful for repairing sperm DNA fragmentation. We have vitamin D3. Vitamin D3 increases the protamine levels and decreases the sperm DNA damage. Its deficiency causes low sperm counts and decreased motility. Studies say that vitamin D receptors and enzymes, if disrupted, can severely impair fertility. Glutathione peroxidase is a potent enzymatic free radical scavenger in the epididymis that protects the spermatozoa from oxidative injuries that could compromise the integrity and consequently the embryo viability. Superoxide dismutase. Actually, I'm having a disturbance in my line. Just 1 minute. Yeah, sorry. Superoxide dismutase, one more important free radical scavenging enzyme. Studies have detected a positive correlation between seminal superoxide dismutase with abnormal sperm morphology, percentage of dead sperms, sperm concentration, and overall motility in male fertility patients. Astaxanthin is far more potent than beta-carotene, alpha tocopherol, and lutein. It exhibits very strong free radical scavenging activity and protects the sperms from DNA fragmentation. CoQ10 has a significant use of CoQ10 causes a significant improvement of DNA integrity. Next slide, please. This slide shows the effects of combined astaxanthin, selenomethionine, coenzyme Q10, vitamin D3 on sperm DNA fragmentation and semen parameters in a single-arm cohort study of subfertile male partners with primary and secondary infertility. The study was to see the effect on sperm parameter and chromatin integrity post 3 months usage of combined supplement in subfertile male partners. Coming to the summary, it showed 57% reduction seen on sperm DNA fragmentation index, around 20% to 8.7% decrease in moderate DFI patient, that is the DNA fragmentation index patient. It showed 38% to 13.8% reduction of DFI in poor DFI patients. And as we see, there was no significant differences in the motility, morphology, or the concentration of the sperm count. So DNA fragmentation index reduced to less than 15% in 94% of all the patients treated with these agents. Next. Yeah, Tribulus territris. This is a slide which shows the effect of oral administration of Tribulus territris extract on semen quality and body fat index of infertile men. For physical health of the sperm, that is the count, morphology, and motility, specific product to prevent and treat sperm penetration and improve the sexual health. Protodiocin increases the active ingredient. Protodiocin increases the level of spermatogenesis by stimulating the Sertoli cells and the Leydig cells, resulting in the increased production of sperms. Most importantly, it significantly improves acrosomal activity and helps the sperm penetrate the zona pellucida and fuse with the oocyte membrane. Protodiocin is derived from Tribulus terrestris. Next slide. Yeah, next, role of Myo-Inositol in male fertility. We'll be discussing that next. Next slide. What is inositol? Now, inositol exists as 9 stereoisomers resulting from epimerization of the 6 hydroxyl groups. The most diffuse form in nature is Myo-Inositol, followed by dichloroinositol. The conversion of Myo-Inositol to dichloroinositol is accomplished by an enzyme with epimerase activity, which is responsible for the different tissue distribution. In fact, every organ or tissue has a specific ratio of MIDCI, fundamental for the correct inositol-related functions. Intestinal absorption of a high amount of MI is considered safe, as highlighted by several studies that prove the absence of side effects even after ingesting large quantities. In addition, in vitro and in vivo results support an increased MI intestinal absorption when combined with alpha-lactalbumin administration. Once absorbed, inositol phosphates are metabolized into unphosphate MI by inositol phosphate phosphatase 1 and then transported to the cytosol of the cells. Next slide. So this is a mechanism. Next slide. MI remains strongly concentrated in the seminiferous tubules. In the spermatozoa, MI plays a key role as an intracellular second messenger through the regulation of calcium levels. It also intervenes in the regulation of sperm motility, capacitation, and acrosome reaction. The activation of intracellular transmission system necessarily leads to increase in cytoplasmic and mitochondrial calcium levels. High calcium levels stimulate the oxidative metabolism, inducing the production of ATP depending on the energy requirements. This system needs a good functional state of mitochondria and consequently a good state of the high mitochondrial membrane protein. Next. So MI role in male. Recently, researchers provide that high mitochondrial membrane protein correlates to higher fertilizing capacity of spermatozoa and to higher spermatic motility. Several studies highlighted an interesting role of MI, which prove able to increase MMP and sperm motility. In the inositol triphosphate form, myo-inositol is involved in the activation of AKT, which is fundamental protein involved in maturation of the spermatozoa. The Myo-inositol in the inositol triphosphate form initiates a cascade of reactions, which always leads to the phosphorylation of tyrosine residues and reflect the state of capacitation that makes male gamete available for fusion with the oocyte, which is actually the acrosome reaction. Next slide. Myo-inositol also represents the second messenger of the gonadotrophin follicle-stimulating hormone. At the testicular level, FSH plays a key role in the control of the Sertoli cell number and function, promoting the differentiation of these cells essential to sustain a normal spermatogenesis. Myo-inositol acting as second messenger regulates the activities of the FSH and thus may result useful to counteract alterations of the hormonal levels. In addition, MI administration lowers the luteinizing hormone concentration. High FSH and LH serum concentrations relate with low sperm concentration. On the other hand, MI increases the levels of inhibin B, which is a glycoprotein secreted from the testes as a product of the Sertoli cells that act as a negative feedback messenger to regulate the FSH secretion. In men, either with normal or altered spermatogenesis, a strong inverse correlation is reported between inhibin B and FSH levels. Next slide. Next slide. This is these are various studies which show the result of in vitro studies using Myo-Inositol. As we can see, majority of them have used 2 milligram per ml of MI. Coming to the results, we can see clearly conclude that absence of amorphous material and reduction of mitochondrial damage to the crest was seen after the use of Myo-Inositol. Use of Myo-Inositol increased the number of spermatozoa with high MMP and decreased the number of those with low MMP in oligoasteroteratozoospermic patients. Increased the sperm motility and the number of spermatozoa after swim-up techniques. And in oligoasteroteratozoospermic patients, the improvement was associated with sperm mitochondrial function. There was improved spermatozoa motility in swim-up selected samples. Fertilization rate with grade A embryos on day 3 was higher. There was also an improved total motile sperm concentration, progressive motile sperm concentration. And patients suffering from varicocele responded in more than 60% of the cases with the use of Myo-Inositol. Next. Next slide. Yeah. So again, just 1 minute. Myo-Inositol significantly increased the percentage of acrosome-reacted spermatozoa sperm concentration and total count and progressive motility. It also helped reducing serum LH levels, FSH levels, and increased the inhibin B concentration. Myo-Inositol increased the basal and after density gradient separation methods spermatozoa concentration. And there was seen to be a significant increase of spermatozoa count after density gradient separation method in the study group. It also showed a significant improvement in the sperm motility. It was seen in at least 85% of the patients studied. Next slide. So what we can conclude it improves the sperm parameters with no adverse reaction. It also increases the percentage of acrosome-reacted spermatozoa concentration, motility. In addition, Myo-Inositol also rebalances serum LH-FSH levels and the inhibin B concentrations. The clinical improvement of idiopathic infertile patients should encourage Myo-Inositol use for the treatment of this disorder. Next. So MI is a safe supplement able to significantly rebalance the serum gonadotropin and inhibin B levels and to increase sperm parameters in patients with idiopathic infertility. MI contributes to balance the hormonal and sperm biomarkers as it acts as a second messenger regulating the activities of several hormones. Next. This is an article showing the importance of Myo-Inositol in male infertility. The beneficial effects of Myo-Inositols on sperm motility and mitochondrial function can be due to their many actions other than the antioxidant properties like insulin sensitizing properties, prokinetic activity, and hormonal regulatory effects. MI plays a pivotal role in reproductive physiology, positively influencing the development of oocytes, spermatozoa, and embryos. Next. Myo-Inositol induces a significant increase in the sperm motility and oxygen consumption, and the main index of oxidative phosphorylation efficiency and ATP production, both in the basal and in vitro capacitated samples. Moreover, there's evidence for a significant protective role of MI against oxidative damage to the DNA, thus supporting its use in vitro fertilization. Next. It is actually repetition of the previous lines. Myo-Inositol would seem to play an important role in the success of spermatogenesis, spermiohistogenesis, as well as osmoregulation of the seminal vesicular fluid, contributing to reduce the viscosity and the presence of amorphous material in the seminal fluid. Moreover, MI is involved in the control of the intracellular calcium concentration, gene expression, cytoskeleton assembly, inhibition of mechanisms that mediate cell death by apoptosis, and in maintaining the mitochondrial membrane. Sperm motility is sustained by a continuous production of ATP from the mitochondrial respiratory chain, strictly coupled to ATP synthase, that is much more efficient in energy production than glycolysis. Mitochondrial respiratory capacity of sperm has been analyzed by oxygraphic approach in order to definitively provide evidence for a specific activity of Myo-Inositol in ameliorating the OXA-PHOS in human sperm. Next. If this is a graph showing the effect of MI on sperm motility, we can conclude that inositol is able to improve the sperm mitochondrial function, thereby improving its motility in patients with altered sperm parameters. Next. Next slide. Zoospermia and MI. Zoospermia is a medical condition wherein a man whose semen contains no sperm or viable sperm at all. It can be classified into 3 types: pre-testicular, testicular zoospermia, and the also known as the non-obstructive azoospermia, whereas post-testicular azoospermia, which is also known as the obstructive azoospermia. Now, it is already evident that calcium ion oscillation, as we saw in the previous 2-3 slides, that calcium ion oscillation is important for cells' basic functions like differentiation, metabolism, and proliferation, followed by survival, growth, and multiplication. So here in the role of myo-inositol comes into effect. Myo-inositol serves as a precursor for the synthesis of inositol triphosphate. It should be mentioned that depletion of the inositol triphosphate can lead to improper calcium oscillation, which results in abnormal production of sperms. Therefore, supplementation with myo-inositol can avoid IP3 depletion and enhance the intracellular calcium oscillation system. Next. Further capacitation and hypermotility, chemostasis, and acrosomal reaction depends on calcium ion oscillation. At a functional level, myo-inositol acts directly on the mitochondria, increasing the membrane potential. The mitochondrial membrane protein is an apoptotic marker clearly related to the functional parameters of the sperm cells, including motility, the capacity of fertilization, and embryo quality, and is therefore used as an index of fertility. High values of mitochondrial membrane protein indicate that the integrity of this structure with optimal levels of activity are associated with high cell viability. Research studies suggest that MI has a significant role in increasing sperm motility and increasing the mitochondrial membrane proteins, probably increasing the cytosolic calcium and consequently the inner mitochondrial calcium. Next. This is a study showing the effect of myo-inositol and antioxidants on sperm quality in men with metabolic syndrome. Next. Next slide. So here, as we see in the study, the impact of in vitro semen supplementation with MI upon DNA fragmentation was addressed in a cross-sectional study done in men and presented at the 2015 ESHRE meet. Although a preliminary report, a significant overall decrease in the DNA fragmentation was determined in the MI-treated sperm, although not expanded to a large group. So myo-inositol impacts on the semen parameters and male fertility. Next slide. Thank you. Finally, it was the last slide. Thank you.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time, ma'am, to check if any question is there.
Yeah.
Not audible.
Hello. Hello, I can't hear you.
Am I audible, ma'am?
Yes, yes.
Yeah, ma'am, as per your practical experience, what will be the effectiveness and safety of this ICSI process?
Hello.
Yes, ma'am.
Yeah, as per my experience, I didn't get the question.
Yeah, ma'am. As per your experience,
if you can chat.
What is the efficacy and the safety of this ICSI procedure?
You are audible, but the voice is not clear. Can you please repeat the question? Or you can put it in the chat. So I don't know.
Okay, ma'am. Okay, ma'am. Okay, ma'am. I'm putting it in the chat box.
No, I'm able to hear you now. Tell me. Ask me.
Yeah, ma'am. So what is your practical experience regarding the ICSI procedures in terms of safety and obviously the efficacy?
Safety and efficacy of what?
ICSI procedures.
I don't know your voice.
Intracytoplasmic sperm injection, ma'am.
Hello, do you mind sending the chat because your voice is not clear? It's
Sure,
not coming clear.
sure, ma'am.
Hello. Hello.
Madam, please check your
Efficacy and
chat box.
safety of ICSI. No, see,
Yes, ma'am.
basically, see, once we advise a patient IVF, that is in vitro fertilization, followed by ICSI, most commonly the reason for ICSI being advised is some defect in the male semen parameters. So basically, safety wise, obviously, it is safe enough with no due risk factors to the firstly, no risk factors to the male partner. Coming to the part, see, before advising ICSI, we usually go for the sperm DNA fragmentation test, wherein we are very sure that whatever sperm we are instilling into the ovum is a healthy one. So overall, from pregnancy outcome point of view, also it is safe enough, provided we have treated the right cause. Like we discussed in the previous slides, if you are suspecting, by giving things like Myo-Inositol, zinc, selenium, these all improve the outcome of pregnancy, the live birth rate. So if we've given a good supplement to the male partner, followed by ICSI, safety is good.
Thank you very much, ma'am.
Yeah.
Am I audible?
Yeah, you're audible.
Okay. Ma'am, and another question is there any medical management in case of varicocele or umbilical surgical treatment is the need of our?
See, mild varicocele, if it is there, mild, grade 1 or 2, and if it is not affecting the sperm parameters is normal, then we don't advise surgical management. And per se, there is no medical management advised. But yeah, if there is a defect if there is subtle changes in the sperm parameters, giving supplements like what we discussed right now, if it improves the sperm parameters, so rather than this can stand as a medical option. It will not treat the varicocele, it will treat the outcome on the sperm, on the semen report.
Thank you very much, ma'am.
Yeah.
So, ma'am, I could not find any other question. So, if you allow us, then we can conclude the session.
Yeah, we'll conclude the session then. Okay.
So, thank you very much, ma'am, for your valuable time on our platform and for discussing an important topic in this today's time. So, thank you very much, madam, once again, and in future also we look forward for some valuable session with you.
Sure. Thank you so much. Thank you, everybody.
Thank you very much, and have a good day.
Yeah, good day. Bye.